This is meeting 2. We have a nice agenda ahead of us. I would ask if you're here with us, please silence your cell phones, and I'm going to ask staff to call the roll.
Senator Douglas.
Here.
Senator Storm.
Here.
Senator Webb. Representative Hart.
Here.
Representative Meredith.
Here.
Representative Wilner.
Here.
Representative Fleming.
Present.
Chair Givens.
Present. I'm informed we do have a quorum and are duly authorized to do business. First item on the agenda is approval of the July minutes. Chair will entertain a motion for approval. Motion and second. All in favor of adopting, accepting, and approving the July minutes, please say aye.
Aye.
Any opposed? The ayes have it. Record will reflect that those July minutes are approved. We have an agenda with 3 items on it today, but before we start, I'd like to thank staff, first of all, for the packet that they've put together for us. I direct members' attention to the information in the packet. Obviously, we have a copy of the minutes that we just approved. We have a 1-page NCSL legislative brief along with slides from all 3 of our presenter groups. In addition, we have a response as provided, I believe, by the Cabinet. Is that correct?
Yes.
The Cabinet has provided a response to our questions around the CON program. If you're in the audience and don't have a copy of that, this information is available on our website or can be made available on the legislative website. Staff is as often will do, they'll say, I should have run these questions by them first, but they'll say yes because they support so ably everything we do up here. But very good synopsis of the CON process, and I would encourage all members to, all interested parties to take a look at that. Someone from the Cabinet, do we have anyone from the Cabinet here today? Yes. One of the asks that I would ask that you follow up on, and there may be others that members have, but my co-chair had asked for a flow chart, and you've done a nice job providing the flow chart of the process. Next to the last line, your box, in accordance with case law, applicant bears burden of showing that the proposal meets the review criteria. That's under the formal review process. If you would provide our staff here with the case law that you're citing specific to that, that would be helpful, and we could have that included in the next packet. All right, with that, we will start with our NCSL presenters regarding the bullet overview of state emergency medical services. And I believe they're presenting remotely for us.
Hello, thank you, Chair. Will I be sharing my slides or will you all?
If you could share screen, that would be very helpful. And please introduce yourself for the record. We're honored to have you join us today, and we appreciate the information that you and your colleagues at NCSL put together and provide for us so ably.
Fabulous. Thank you so much. Thank you, Mr. Chairman, and thank you, co-chairs and members of the task force for having me. I am Kelsey George. I'm a policy associate with the National Conference of State Legislatures Health Program. And I'm joined here today by my colleague, Kelly Hughes, who's the Associate Director of Access, Costs, and Coverage for the health program. NCSL is the bipartisan organization serving state legislators and legislative staff in America's 50 states and territories. We create opportunities for lawmakers and staff to share knowledge and ideas so they can enact laws and policies that improve the lives of their constituents. At NCSL, I cover policy issues related to health workforce and rural health, and that includes emergency medical services focus here today. I greatly appreciate the opportunity to talk with you all about state policies addressing EMS. And Kelly, we're not in presentation view yet, but if you can go to the next slide.
I'm so sorry. Just give me one moment and I will get that set up. Thanks. I'm sorry, this will take me a minute. Kelsey, if you're able to more quickly, please feel free to. Otherwise, I just need to adjust some of my screen settings. Sorry about that.
try this. Can you all see it in presentation mode?
It's not in presentation mode yet.
We can certainly see your slides, and
Okay.
you're welcome to move forward even though it's not in presentation mode. And if you change in the midst of stream, it'll be perfectly fine. We're very appreciative of you being engaged and involved with us today. And this was on relatively short notice, so thanks for pulling this together for us.
Fabulous. Thank you, Mr. Chairman. So for today's presentation, I'll provide a brief overview of state EMS and then provide a deeper dive into workforce strategies to address the shortage and or maldistribution of EMS clinicians, certificate of need laws and other state efforts to increase access to emergency medical services, and reimbursement by private and public payers for emergency services. So EMS systems vary greatly across structure, administration, and workforce, and I'm going to touch on each of these during my remarks today. In terms of structure, agencies may be government, healthcare, or privately owned. If they're administered by the government, they're most often administered through either a fire department, law enforcement, or as a standalone EMS service. And there's a lot of variation across workforce. So agencies may employ EMS clinicians who are either volunteer or paid members, or they may have a mixture of the two. And agencies may also consist of a mixture of full and part-time clinicians. In addition, clinicians may also hold multiple positions across several agencies. So the workforce varies greatly across states and across communities. Because of these variations, if you've seen one EMS system, you've likely only seen one EMS system. Before we dive into EMS state policy, I want to take a moment to examine how Kentucky's structure varies from the national landscape. The pie charts pictured here show a general benchmark of ambulance agencies nationally and in Kentucky. It's important to note that these numbers are fairly close comparison, but they are from different years, and the two organizations don't necessarily categorize agencies in the same exact way, but it provides a general snapshot of agencies. So as you can see, the US has a slightly higher overall proportion of EMS agencies that are based in fire departments, while Kentucky has a higher prevalence of private or other community-based and nonprofit ambulance agencies. NCSL has been tracking EMS legislation across the 50 states and territories in our publicly available database since 2021. The information I'm sharing here today is largely pulled from that database. And many of the examples I'll share today are from Western and frontier states, and that's because they've been grappling with many of the same challenges around EMS that you all are, because they are largely rural. But overall, we see that providing timely and quality emergency services to all residents is a commonly shared priority across states. The EMS workforce includes emergency medical responders, or EMRs, emergency medical technicians, EMTs, advanced emergency medical technicians, AEMTs, and paramedics, as well as other EMS clinicians, including nurses and physicians. EMRs tend to initiate immediate life-saving care to critical patients while awaiting additional EMS response. EMTs provide basic emergency medical care and transportation for critical and emergent patients. AEMTs, in addition to the responsibility of EMTs, may provide limited advanced emergency medical care. And paramedics, as the most highly trained individuals, provide advanced emergency medical care and transportation for critical and emergent patients. Each of these clinicians operates under a license to practice within a state, which dictates the tasks that they're able to perform under their license. And ideally, these positions provide a career ladder throughout the profession, starting with EMRs going through paramedics. States, in terms of licensure and certification, states have the authority to license EMS clinicians to practice, including setting education and training requirements. The National Registry of Emergency Medical Technicians, or NREMT, is the primary certification body for EMS clinicians in the United States. NREMT serves as the basis of licensure in 45 states and the District of Columbia, including Kentucky. In order to recruit additional EMS clinicians into the workforce, some states are looking at lowering the age required for licensure from 18, which used to be NREMT's requirement, to 16 or 17 years old. So expanding the pool of who can apply for licensure. 9 states have lowered the age requirement for EMTs, and at least 3 states, New Jersey, Virginia, and Wisconsin, allow individuals to attend EMR or EMT training courses or apply for a training permit before their 18th birthday. In addition, Minnesota and the US Virgin Islands have funded career pathway programs for high school students to pursue careers in EMS. So career pathways introduce students to healthcare careers through education, training, and other services that align with the skill needs of the community. In addition to looking at lowering licensure age requirements, states are also joining the EMS Compact. The EMS Compact is the interstate licensure compact for EMS clinicians, including EMTs and paramedics. The compact allows those clinicians to practice across state lines as long as their state and the state they're practicing in both participate in the compact. And there are currently 22 member states and an estimated 325,000 participating clinicians across the country as of this year. The compact became active in 2020, and the most recent state to join was Pennsylvania just earlier this year in 2022. And I would like to pause here for a moment to recognize a common challenge in the EMS workforce, which is data collection. Tracking the EMS workforce, including volunteer clinicians and those that may hold multiple positions across several agencies, is complex and varies across states. So this makes it challenging to estimate workforce shortages and maldistributions, as well as the impact or outcomes of state initiatives around this area. So for this reason, I wasn't able to identify any specific outcomes, such as an increase in EMS clinicians practicing within the state for states that have joined the EMS Compact. But we do know anecdotally, however, that states participating in the compact reported interstate licensure as a useful tool to address surges in demand during the COVID-19 pandemic and wildfire responses in the last couple of years. Also, under the umbrella of workforce scope of practice, so states also set the tasks that EMS clinicians are allowed to perform under their license to practice. This is known as their professional scope of practice. The National EMS Scope of Practice model was developed in 2007 and revised just in 2019. And that serves as the foundation for scope of practice of EMS clinicians in all 50 states and the territories. Among EMS clinicians, paramedics are the most highly skilled medical providers on emergency response teams, but once they reach this level of training, they're often in high demand. Larger departments, predominantly in urban or suburban areas, may be able to boost pay and offer signing bonuses, while smaller departments, often located in rural communities, may struggle to compete to recruit and retain those individuals. Nationally, we're also seeing a trend of EMS clinicians, particularly paramedics, leaving the profession for a career outside of EMS. Such changes include moving to registered nursing jobs. These positions tend to earn double the salaries of paramedics nationally, work in more settings like clinics, hospitals, schools, nursing homes. They have more advancement opportunities, they require less stress, and they're also in high demand. So while the scope of practice between paramedics and registered nurses is not comparable one-to-one, many universities offer paramedic to RN training programs that provide or that build on the field-based education and training that paramedics already possess to prepare them for the responsibilities as a registered nurse. To address these challenges around recruitment and retention and scope of practice, some states have expanded the scope of practice of other EMS clinicians. So upon completing additional education and training, allowing additional EMS clinicians to perform other tasks to fill gaps in the workforce. This includes Montana. So under the authority granted by the Board of Medical Examiners, Montana allows local EMS directors to expand the individual emergency care personnel scope of practice. So after an individual completes education and verification, they may provide a higher level of care, such as administering intravenous fluids or IVs. Finally, under the umbrella of workforce, recruitment and retention. So The recruitment and retention of EMS clinicians is a major challenge, especially in rural communities. States are responding through legislation to address compensation, benefits, and mental health resources for EMS clinicians. Many states experience a challenge recruiting and retaining paramedics in rural communities where budgets may not be able to offer boosts in compensation or sign-on bonuses. Rural EMS agencies also tend to be more dependent on volunteers than those in urban or suburban communities. Nearly 3/4 of volunteer EMS clinicians nationally work in rural communities compared to 30% of paid professionals. Under compensation, compensation or pay is often cited as one of the top reasons that EMS clinicians leave their positions. So in order to recruit and retain EMS clinicians, several states have turned to state tax credits to supplement compensation. Iowa, Nebraska, and Oregon, for example, provide income tax credits ranging from $100 to $250 to compensate volunteer EMS clinicians for their services provided throughout the year. Under benefits, EMS has one of the highest rates of injuries and illnesses of all occupations, but many part-time and volunteer clinicians may not be eligible for employee-sponsored health insurance or other benefits. Some states are looking to address this and recruit and retain EMS clinicians by providing state employee benefits. For example, Utah created the Volunteer Emergency Medical Service Personnel Health Insurance Program. This made health insurance coverage available to licensed EMS clinicians that are employed by a local government entity under the state employee plan. And Idaho made EMS clinicians at the state, county, and municipal level eligible to receive retirement benefits. And finally, under mental health resources, in addition to addressing physical health, EMS clinicians face high levels of acute and chronic stress, as well as high rates of depression and substance abuse. This increases their risk of suicide and other mental health conditions. Research shows that burnout levels increase with the number of years that an EMS clinician stays in their position, as well as is higher among clinicians who work shifts that last longer than 12 or 24 hours. To address this, Utah, for example, established a grant program that provides mental health resources to EMTs, AEMTs, paramedics, and first responders. This includes regular and periodic screening and access to mental health treatment and services for all current first responders, their spouses and children, their surviving spouses if they're killed in line of action, and retired first responders. Moving on to the next section of Certificate of Need. I know you all had a bit of a conversation about this during your last meeting, so I won't dwell here, but Certificate of Need or CON programs are state regulatory mechanisms for approving major capital expenditures and projects for certain healthcare facilities. As the map on the right shows, 35 states and the District of Columbia maintain some form of a CON program. Most of these programs regulate hospitals, outpatient facilities, and long-term care facilities. Kentucky is just one of 2 states alongside Arizona that include ground ambulances under their CON program. Arizona requires a review process for ground ambulances based on population density, geographic, and medical considerations. There are 2 states with CON programs that specifically exempt ground ambulance services. That includes Tennessee and New Jersey. And then a few states maintain CON review processes for air ambulance services. Most are preempted by federal law under the Airline Delegation Act, which regulates air carriers and a competitive marketplace for air carriers nationwide. So those states include Arizona, Florida, Hawaii, Iowa, North Carolina, and Michigan. And then finally, under reimbursement, at the federal level, emergency medical services are considered a transportation benefit under Medicare and Medicaid. This means that many ambulance agencies don't get reimbursed unless they transport a patient to a facility, such as a hospital or emergency department. States have used several strategies to increase reimbursement for EMS services outside of transportation to an emergency room, including supplemental payments, treatment without transport, and alternate destinations. Some states provide supplemental payments to ambulance agencies to cover services that do not result in the transport of a patient. Georgia's Medicaid state plan amendment provides ground ambulance providers that are affiliated with an enrolled hospital with supplemental payments annually. The National EMS Management Association estimates that 40% of ambulance calls are not emergencies. And in some cases, this may be the only means by which a patient can access primary care, or they may require treatment for an unmanaged chronic condition like diabetes. Treatment without transport provides the ability for EMS clinicians to provide care to patients without transporting them to a healthcare facility. 14 states provide reimbursement for treatment without transport. And under the umbrella of treatment without transport lies community paramedicine, which is a form of mobile integrated care that connects patients with non-emergent or non-urgent needs to primary care and other services through EMS. Those services may include connecting patients to primary care, completing post-hospital follow-up care, providing education and health promotion, and providing services that are otherwise not available within their community. These services are provided by paramedics under their current scope of practice that they're licensed to perform. Kentucky currently requires private payers to reimburse for community paramedicine services. Other states require public payers to reimburse, including Indiana. Indiana Medicaid began reimbursing for community paramedicine in 2018, and the state established grant programs in 2019 and 2020 to assist communities developing mobile integrated healthcare programs. And last but not least, at least 7 states allow EMS clinicians to transport patients to alternate destinations other than a hospital or emergency room. These may include primary care clinics, urgent care centers, social or psychological services. And for example, this includes Louisiana, which allows ambulance providers to transport a patient to an alternative destination when the individual's condition does not meet the definition of an emergency medical condition. And with that, I've included a few resources here, including NCSL's EMS legislative database, our new policy brief on the EMS workforce and recruitment and retention, as well as a couple of web pages on community paramedicine and certificate of need laws. And that concludes my presentation. Thank you again for inviting me to present on EMS and what we're seeing within the states. I'm happy to answer any questions, or feel free to reach out to me directly.
Ms. George, thank you for the presentation. Certainly, I feel like there will be some questions. I'm going to start off with one or two very briefly. Early on in the presentation, on the second or third slide, where you have your workforce bullet along with your EMS overview bullet, CON bullet, reimbursement, you mentioned the word maldistribution. Maldistribution of the workforce. Expound on that for just a moment.
There's conversation about whether within workforce, whether shortage is an accurate term, and that may be a state, while your state may be experiencing a statewide shortage of EMS clinicians, there may also be a maldistribution between, for example, urban and rural communities. So urban communities may have enough clinicians or more than enough clinicians, even in some cases that we're seeing across the country, while rural communities may be experiencing shortages. And again, that goes back to some of the structural and budgetary differences between those agencies, depending on how they're structured, how often they rely on volunteer EMS clinicians, and what sort of benefits and compensation they're able to offer.
Great. Another question I had was on your legislative database. You mentioned 26 states enacting 44 bills in 2022, and then you list the series of buckets that the bills fall into. Among those buckets, was there a specific bucket that was the biggest, that got the most legislative attention? Was it workforce? Was it one of the other concerns?
Thank you. I would say under those buckets, we're seeing the most action around funding and workforce at this point, largely because, like I said, states are grappling with how to ensure that EMS services are efficient and accessible, and funding and making sure that they have enough workers within that.
So the rest of your presentation, you did a wonderful job providing some food for thought as we talk about recommendations at the end of our work together. Lowering licensure age requirements, that's one that I think we may well investigate some. You mentioned that some states were doing so and others weren't. What is the position of the National Registry now as it relates to age?
They recently removed their age requirement as part of licensure and deferred to state authority. So some states, as a result, have lowered the age requirements for licensure. But it is my understanding that they are not taking a position, but deferring to states in that regard.
Very good. We, in our health policy, medical policy here in Frankfurt, we never discuss scope of practice. I mean, we never, ever, tongue in cheek, I'm being a little on the edge here, discuss scope of practice. So we're not going to discuss that one today either. So when we talk about, certainly that is one we will take a look at. When we talk about other bullets that caught my attention, your reimbursement slide is one that I think I'd like to spend a couple of minutes on. If you'd pull that slide back up for us. So the majority of states do not reimburse for services unless a patient is transported to a hospital.
Yeah.
Explain again the reimbursement logic around what's going on this slide, because I think there's a lot of interesting information here.
Absolutely. So at the federal level, at least, and some states have changed how this looks within their state Medicaid programs, but from the federal perspective, under Medicare and Medicaid, EMS is treated as a transportation benefit, not as a healthcare benefit. So reimbursement is only provided when patients are transported to another facility, as opposed to the care that an EMS professional or a clinician may provide on site. So if an EMS clinician, for example, goes to address a situation and it's, like I said, it's a chronic condition that a patient needs help monitoring, or they're looking to access primary care and they don't have it in their community, they may call 911 with what they think is a health emergency, but it may not rise to that same level. So they may not require transport, in which case, most often ambulance services are not reimbursed for that level of care.
The states that are being able to do it, the Indiana Medicaid began reimbursing for community paramedicine in 2018. Does that require a waiver? How is that process put in place and achieved?
I can look into that more specifically. I believe it is either done through a waiver or a state plan amendment, but I can look into that and get back to you with more information.
That would be great. Any other colleagues with questions of this presenter? Co-chair?
Thank you, Co-Chair Givens. Thank you very much for coming and give us a pretty good detailed presentation and stuff. I want to get just a clarification. I think it's on slide 7, and I'm trying to get my head wrapped around what you said in terms of workforce. You said that data collection is difficult to gather throughout the country based on workforce. Is that what I heard?
Yes. So while data is collected through the National Emergency Medical Services Information System on specific incidents of care, actual data on the workforce is very difficult to collect. There are some organizations like the National Association of State Medical or State EMS offices that does some occasional surveys on the topic. But in general, states collect data differently, and so it's difficult to compare across states in that regard. And for that reason, it's also because they're measuring across volunteers and part-time employees that may be working at multiple agencies, it's difficult to track the outcomes of some of these workforce interventions.
Let me follow up another question. Trust, this is not to be a smart question, okay, or anything, but I'm trying to get my head wrapped around the workforce. And I know intuitively and speaking with folks, there is a workforce issue, but I don't feel comfortable in terms of quantifying that data in terms of really where they fall into those different practices and disciplines and so forth. I mean, I hear it, and some people have mentioned it to me, but I'm trying to connect the two, because if we're going to go forward, and I think workforce by and large across the spectrum from teachers to to firefighters to police, there's a significant issue. But what I'm thinking of in terms of how we want to structure what we're going to come out with, some dollars or some incentives we're going to have to follow through with that. Can you expand on that, or enlighten me a little bit on that in terms of validating that the data, make sure the workforce is actually there?
Yeah, I believe that there are some states who have allocated money to study the workforce specifically. We've seen that in other professions like nursing, or some other support positions, like peer support specialists and things like that, which I know has happened in other professions. I believe there are a few states that have done that within emergency medical services. But generally speaking, I would defer back to your state authority, the Kentucky Board of EMS, or another local individual to talk about the Kentucky EMS workforce specifically.
Okay. All right. Thank you. I want to shift gears just a little bit. The co-chair mentioned about reimbursements, and that seems to be sort of a hot topic across the mental health as well as healthcare professions. And I'm going back just a moment, your number 4 structure and appointment, you looked at national how it's broken up between private and fire departments and hospitals, and look at Kentucky. Can you talk about any in terms of how the relationship is in providing that service as it pertains to reimbursement? And what I'm trying to drive towards is one thing I'm contemplating, and it's been discussed with some colleagues, is about value contracting. And if there is some type of value contracting, you have to have data supporting that and make sure that whatever that's being provided, that we're having good outcomes. And I think we see that in the rural part of this state, as well as you mentioned other parts of the country. We need to be conscious of providing that service, but also I want to make sure or think about how we can improve that. So it's a little bit of a value contracting. Does that make sense?
That does make sense. I'm not aware of anything off the top of my head, but I can do a little bit more digging and follow up on that specifically to see if other states are pursuing that as an option as well.
Okay, thank you very much. Thank you, Co-Chair.
Representative Hart, you had a question.
Real briefly, on the slides that you have up there, you mentioned 22 states have now adopted the EMS Interstate Licensure Compact legislation. This has been a bill that I've been working on for the past couple sessions, and I'm just curious, out of the 22 states that's already enacted this, have they seen any positive growth in their workforce or negative? How's it affected their workforce as far as recruiting and getting more paramedics and EMTs?
So I have reached out to the EMS Compact directly on that question, and they don't have any specific studies or state examples that have looked at, ultimate numbers of EMS clinicians practicing, for example. But they did share that anecdotally states have shared that during the COVID-19 pandemic and during certain wildfire response surges in the West, that they have seen that interstate licensure compacts and allowing EMS clinicians to practice across states help them address those particular situations. And that isn't the ultimate purpose of the EMS Compact. The EMS Compact is meant to facilitate the day-to-day practice of EMS clinicians across states, but that is one outcome that we've seen so far. But I don't have any specific data, and they didn't have any either on how states have experienced workforce fluctuations after joining.
All right, thank you.
Ms. George, thank you. Wonderful presentation. As always, NCSL comes through with some talent. Thank you for bringing that together for us and for the wealth of knowledge you've provided. So we started with the national view as provided by NCSL. I'm going to jump out of order on our agenda today, and we're going to move down the next step to what I'm going to consider a regional view as we bring Paul Phillips with Global Medical Response forward. He's the regional director. Paul, if you'll come on up the table, bring your guest with you. This bullet is State Emergency Medical Service Challenges for Ambulance Service Providers. Paul, if you'll introduce yourself and your guest, and please proceed with your presentation.
There we go. All right, well, Mr. Chair and members of the task force, we really appreciate the opportunity to come and present today. One of the things that I wanted to do before we actually present, we've had some crews in eastern Kentucky operate in the eastern part of the state that have been incredibly affected over the past few weeks with the flooding. And I just wanted to take a moment to recognize them. They have been they've been through the ringer. And I wanted to share a story. And I've told this story several times. I try not to get emotional when I speak of it, but it'll be tough. So we had an employee whose home was swept away during the floods. He got his family to safety. They're doing great. They're fine. But he went back to work. And his supervisor looked at him and said, "Hey, man, take some time. Just breathe. Go be with your family for a little bit." And he turned and looked at his supervisor and he just said, "Where am I going to go?" And then he turned around and he let him know, "Look, my family's safe. I'm fine. We're going to be okay. But there's people that aren't, and I need to help them." So I really wanted to recognize that that's the heart of a first responder, but it's also the heart of an Eastern Kentuckian. It's a strong group. They're very tight-knit. And I couldn't be more proud of my crews in Eastern Kentucky and all of the crews in Eastern Kentucky. They have absolutely risen to the challenge over the past few weeks. I had a base in Knott County who went a week without water, and there's still residents there without water. And I just wanted to recognize them because they have been doing a tremendous job. So I appreciate you entertaining that. So we'll get into our presentation.
Paul, let me
Yes,
interrupt
sir.
you for a second. If you could, for the record, we have to have you formally say who you are, what you do, and who your guest is with you.
Absolutely. I am Paul Phillips. I am the regional director for the ground operations in Louisville, Lexington, AMR, and then Eastern Kentucky Lifeguard Emergency Medical Services. With me is Terrence Ramatar. Terrence is the regional director for government affairs for the 13 states of the Southeast region within Global Medical Response.
Well, and thanks for having us. Just a little bit about GMR, Global Medical Response. We're a national provider with a heart and local EMS. We operate over 8,000 vehicles across the country, 352 rotary wing aircraft or trauma helicopters, and a whole host of other emergency type services across the country. We employ 35,600. That number used to be in the 40s, so that has come down quite a bit. But we service over 4,000 communities with air bases, communication centers, fire stations, a whole gamut across the country. You can see a little bit of our service map there. And I'll turn over to Paul, who runs Kentucky.
Sure. So just to give you a glimpse of our footprint within the state, we operate in Lexington, Louisville, Owensboro, Northern Kentucky. Those are AMR branded solutions. And then in the eastern part of the state, we operate in Floyd County, Harlan County, Knott County, Leslie County, and Pike County. Those operate under the Lifeguard Emergency Medical Services banner. So that just wanted to give you guys an idea of our footprint. What we're going to be presenting on today, kind of wish we had gone first because I think a lot of our things are going to echo what was just presented, but we're going to trudge along nonetheless. We're going to be presenting on reimbursement issues, which is kind of how EMS is funded in the state. And then we're going to also speak to access, and that can include the logistics of actually doing the transports, basically how we get patients transported from their home, how we get them to definitive care, basically getting the patient to the right place at the right time. And then we'll speak to some of the specific challenges within the workforce within Kentucky, and also some of the things Terrence will speak to as far as what is going on nationally.
Yeah, thank you. So obviously this is a recognized problem across the country in every state and every community that we service. Those three issues being recognized by the American Ambulance Association, that's DC based. I happen to be a board of director there, and the National Association of EMTs. We've been advocating on Capitol Hill for a number of relief items, including grant programs, access to federal grants, funding for recruitment and training, and looking at how we can implement programs in rural areas, minority areas, low-income areas, how we can develop that workforce. But I'm going to speak to reimbursement because I think when we talk about those three things, we talk about anything where there's no margin, there's no mission. So it's really important that we address reimbursement. A little bit how we are funded, how ambulance services are funded, whether you're private, public, or whatever. Most of us, if you're not volunteer, bill for the services to get reimbursed. So our major payer sources are here in front of you. And I just want to speak briefly about some of the behaviors that we're seeing and some of the challenges that we have with our current payer sources. Medicare, as you know, reimburses us or most of the healthcare industry below the cost of providing services. So we've been advocating for decades to continue to increase the Medicare reimbursement rate for ground ambulance services to try to even get close to what the cost of providing services are. Medicaid, we'll talk a little bit about, that is controlled within the state. Commercial insurance, we're seeing a lot of changes within that landscape as it applies to in-network and out-of-network. And I don't want to open up a can, but I just want to talk a little bit about that. So commercial insurance providers, if we're not in-network, we charge usual and customary rate, and most of those charges across the state and the communities are reflective of the service level you want to provide, or the level of clinical expertise that's in that area. There's a charge behind that. Obviously, if you're in a rural area, it's probably more expensive to get to keep ambulances afloat. So, commercial insurance is if you have not signed an agreement to be in network and accept what they want to pay you. Will pay you what they deem necessary. So we're currently in a struggle with commercial insurances to try to get them to reimburse us for the cost of providing that service so patients don't get a balanced bill. Private pay, post-pandemic, we saw a huge increase in the private pay, uninsured or underinsured. So those folks that were carrying health plans that were able to reimburse for the services, the unemployment rate was affected there. So we did see a decrease in reimbursement there, and we definitely saw an increase in the underinsured. And tied to commercial insurance, now what we're seeing are these health plans with these astronomically high deductibles. So if you are in a vehicle accident or need to be transported to the hospital, and we bill your insurance, and it's January, at the beginning of your plan year, then you're responsible for that. So we do see challenges there in EMS in terms of the first quarter of the year getting reimbursed for our services because most of that is out of pocket for the patient. So we're looking at ways to address that and working with the insurance providers to come to an agreement on what the cost of services should be. Our payment model, as mentioned before, we're paid for transport and not necessarily treatment. So most of the fee schedules in Medicare, Medicaid, or even commercial side are based on transporting a patient. There's limited to no reimbursement with some exceptions in pilot programs, and some states are now starting to implement some pieces of this, but there's really no reimbursement for readiness. So a Medicare patient or a Medicaid patient, that fee schedule pays us a fixed amount, whether we got there in 5 minutes or whether we got there in 20. There's no difference there. We just have to remain ready and meet the expectation of that community. So there's no reimbursement for the response. All this up until we get on scene is not covered. When we get on scene is when we treat the patient. If the patient is not transported, but we do treat them, in a lot of instances, the majority of the instances, we are not reimbursed for that. So the case of a diabetic who, in the middle of the night, their sugar drops because maybe they over bolused on insulin or didn't eat enough, and their sugar level drops, and their loved one calls 911 because they don't know what to do. Maybe this is a diabetic for 20 years and knows how to manage himself for the most part, but that night may have had a bad night. So what we do is we show up, we treat the patient, maybe we'll administer some glucose, maybe we'll get him going, we'll wait, we'll check his sugar, And a lot of times those are patients that probably don't need to be transported. So we'll call the physician or talk to someone at the hospital and not transport those patients. That entire time that we've responded, treated the patient, got back in service is uncompensated. So there's mostly no reimbursement for that. When patients refuse care, we show up on scene, we evaluate them, we assess the situation, we assess the patient to see if there's a medical emergency. That's all time being consumed. We do not generally get reimbursed for that time. So I think it's wanted to make sure we communicated that. When we look at Kentucky Medicaid, and specifically, it's remained flat for at least 10 years. That's as far back as we can go, but we're not finding any traceable evidence of the last Medicaid fee schedule increase for ambulance services. The cost of providing services, I can't harp on enough. Fuel, the cost of vehicles. In a lot of areas we're seeing we're not able to get vehicles because of the chip shortage. There's some departments that are waiting 1 to 2, even 3 years to get an ambulance on the ground because of that. Required medications. I think it's important to note that over the decades that EMS has been progressing, we've kept up with the scope of practice. We've kept up with advancements in the industry, advancements in medicines. We're carrying a whole lot more medications on board than we did in 1974. We've done that. We've done that despite the reimbursement, because we need to make sure that there's adequate level of care or maximized level of care we can provide on scene for these patients. So as we continue to progress and advance the level of care that we are giving, we still struggle to get insurance companies or payers to pay for that. Significant investments in physical infrastructure and buildings and wages, and we'll talk about that a little bit more in detail. But Medicare and Medicaid, just want to make sure that those are fixed fee schedules. Medicare will increase their fee schedule just slightly every year, but certainly not to where it compensates us for the cost of doing that service. Comparatively, we decided to pull the Medicaid emergency ambulance reimbursement rates from surrounding states and show you this on this chart. There's 2 types of ambulance calls in the 911 sector in terms of emergency: is advanced life support and basic life support. They're 2 different reimbursement structures, whether the person needs basic life support care or advanced level paramedic care. These are the reimbursement rates. You can see that we as a state, Commonwealth and Kentucky, struggle amongst our contiguous states, at least, to keep up with reimbursement. We did, we passed House Bill 8, I think 2 years ago, which provided some significant relief in terms of a provider tax to pull down some more match, to increase the reimbursement for emergency. But when we look at non-emergency ambulance reimbursement rates in this slide, you'll see that Kentucky still trails behind the surrounding states in terms of what we can get reimbursed for. Those ALS and BLS rates are $60 and $70 respectively, which is significantly below the cost of providing ambulance services. I'll turn over to Paul to talk about access.
So I think what we're going to talk, excuse me, when we discuss access is basically kind of what the last speaker touched on, was access to systems of care. A lot of the challenges that we're seeing from, especially in the rural area, is with having only 2 level 1 trauma centers in the state, and there's really only 1 additional level 2. The 2 are in Lexington and Louisville, and then Pikeville has the additional level 2. Well, the problem is with that, it leaves a large gap within the state for that type of care. And we'll see that I've got some maps on here. Will show that there are some large gaps between the stroke centers too. And as many of you know, those are time-sensitive issues, especially with the stroke. Like if you don't get to a definitive care institute within a certain amount of time, a full recovery is not guaranteed, which it's not ever guaranteed, but the likelihood goes down exponentially. So I'll speak to some of my ambulance services in Eastern Kentucky. So if we transport, and here we'll show the map, we just wanted to kind of show that there are certain counties here in the state that don't have a hospital in them. And what was kind of jumped out at me was the finger that goes out just east of Montgomery County there, that there's a gap within several counties there. if you can go on to the next one. So this is the trauma system map. So you'll see the two in yellow. Those are the level 1. That's Fayette and Jefferson County. And over on the east is Pike County, and that's Pikeville, and they're the only level 2 for the state. There's several that are in process for the level 3 and level 4, but there's a significant, especially in South Central Kentucky, a pretty big gap there. So what I was touching on before was, if, let's say, one of my ambulances from Leslie County were to pick up a patient at the local hospital and have to take them to the trauma center at UK, so you're looking at 2.5 hour transport time. So you've got 30 to 45 minutes to where you go into the hospital, access the patient, package them, get them to the ambulance, prepare them for transport. You move them the 2.5 hours. You get to UK, you've got a similar incident, 30, 45 minutes, where you've got to offload the patient, transfer care, do all the things that you need to do to make sure that that patient will continue receiving the quality care that they need. So now you're 4 hours, 5 hours into a transport. Well, now you've got to turn around and drive back. So that's 7.5 hours at this point. The problem is that, and when we speak of reimbursement, and Ms. George touched on it as well, there's this maldistribution of reimbursement, where there's large pockets of Medicaid and underinsured citizens. Then there's not enough volume to support having maybe more than a couple of ambulances. So if you've got one that's on a transfer to Lexington, then you get a emergency call within the county, you're left with no ambulances at that point. And with every ambulance service adjacent suffering from the same problem, there's not a whole lot of opportunities to aid each other from one county to the next. What we did here, just step back. So this is basically a transfer pattern distribution. So we showed from and this is from our data only, from within AMR and GMR. We took all of the transports that for 2021 that were greater than 50 miles and just kind of showed the distribution and where they're going to. You'll see a great deal of them are going to Lexington and Louisville. Of course, if you're in northern Kentucky, there may be a possibility that Cincinnati's closer, or there's, you're going north, which is understandable. There's even within Owensboro over on the west side, there's a fair amount going to Evansville, Indiana. So just kind of wanted to show the distribution, and then also kind of illustrate some of the ills we're having with the long distance transfers. So another issue with access and just getting the patient to the right place is mental health transports. So I want to kind of talk about medical mental health versus non-medical mental health. And I don't at all want anyone to think that we're downplaying the illness of mental health, because that's a true need. But medical mental health actually also has a medical diagnosis that requires ambulance care. There are non-medical mental health patients who are being transported in ambulances because it's an opportunity. We're kind of the transport arm, so we get tasked with that as well. So when we talk about the non-reimbursement model for the non-medical transports, there isn't really a reimbursement model outside of maybe a contract with a healthcare facility or billing the patient for these non-medical transports. So a lot of times they're longer distance transports as well. It's not maybe the adjacent county. You may be going 2, 3, 4 counties over to transport to a place that can actually give this patient the appropriate care, because those are specialized instances for these patients. We also have the problem within Kentucky that EMS personnel are not allowed to detain the patient. So there's a difference between restrain and detain. So restrain, we can take a cravat or some type of device and try to help the patient stay on the stretcher. We can use the straps that go on the stretcher. But if the patient wants out and they get out, it's actually stated in the Kentucky State Protocol, we do not pursue them because we don't have any rights of detention. It's actually, it would be considered kidnapping per se for us to hold them against their will. So, and I'll big on anecdotes. So I actually had a Louisville crew get assaulted by a mental health patient. They got out in a rural area. They were transporting the patient to a mental health facility. The patient overtook the crew, and one of my crew members ended up with a broken wrist. So and I say that just to highlight that there is a real issue, and a lot of times I feel like we get a little bit of a bad rap because we're not able to do all the transports. Part of the reason is some of us have been burned before, and it comes down to making sure that our crews are safe, which is always going to be my number one aim.
I'll talk. Try not to be repetitive because I think through these meetings, everyone understands we have workforce challenges. So I want to talk just a little bit more about that. Nationally recognized now, I think finally we got some sort of data nationally from HRSA that's reporting that by 2030 there'll be a need for an additional 42,000 EMTs and paramedics across the country. Like we talked about, data is very hard to get here. In this industry for a number of reasons, but we do know that we've got an aging population. We've got baby boomers that are retiring. We've got healthcare demand that's continuing to increase. So our problem is quickly outpacing the solution. We're seeing it all over. We're seeing it in news journals, industry journals, and national networks are now reporting shortages in emergency medical services. We talked a little bit about turnover, but and the former person who presented did cite this, but 20 to 30% turnover is what we're experiencing in our industry, which means every 4 years we're turning over the workforce. Now, pre-pandemic, we've sort of modeled to that, right? So we know that EMTs, this is a stepping stool type of work for them. They get into other forms of healthcare. They become paramedics, they become nurses. They go into that sector, or they get into firefighting or go into some sort of other related career. So throughout the pandemic, what we saw happen was sort of a freeze in the education process and the training process, and something that never recovered. Coming out of 2020. So we did see across the country, we saw lower enrollment in EMT and paramedic programs. We're also experiencing some lack of interest. I think we have a high school population now that's getting more into technology and some other industries versus healthcare and some other industries that suit somebody coming out of high school. So we're working really hard to display the industry to high school students and those folks that are coming up through the education system to show them that this is an option. But what's important? It's a finite resource. So if we when we start today to train someone from the street to become an EMT and eventually a paramedic, that's approximately 2 years. So right now, what we're also seeing is paramedics being recruited to work in non-traditional environments. So we're seeing paramedics being recruited by hospitals and emergency departments to provide clinical care within that type of setting, which we didn't see much of up until about a couple of years ago. We're seeing them being employed in long-term care facilities. We're seeing them being employed more in industrial workplaces like car manufacturing plants, that sort of thing. So in addition to the shortage and the pipeline shortage, we also have the current workforce that's looking to get out of this environment into another environment to work in. We're also, another important point, we're losing paramedics in the Commonwealth of Kentucky to more concentrated areas within the state, which I think the term maldistribution was used. But also we're seeing them move out of state. So they're chasing higher pay, which is another symptom of reimbursement, right? So they're moving over into Tennessee, they're working over in the Cincinnati area. Those sorts of things, we're seeing that happen. Overall, look, in the workforce, we've got a lack of data. That's an obvious here. Our applicant pool has diminished, so we are now doing programs to find folks willing to become EMTs. In fact, in a couple places across the state, we're actually paying folks to go to school, a full-time salary plus their tuition, to become EMTs. So we're having some success there. Just the challenges to find where and how. Retention is an issue. I talked a little bit about that, and then the inability to increase wages. So we talked about the fixed reimbursement. So we're capped in reimbursement to a certain extent, which means we're also capped in what we can do for increasing salaries to the max. So we're also seeing now a lack of career advancement, which you talked about, and keeps maldistribution. I'll put that in my dictionary. Yeah. But unequal distribution of staff across the Commonwealth. So rural areas are losing their paramedics to more concentrated areas, and it's becoming very difficult for the rural areas to attract them back to work in their own communities. We did have some success in the HHS appropriations package just a couple weeks ago. We did see a recognition of EMS as part of the national workforce shortage, and we're hopeful that on a federal level they'll work through some solutions there or help us with grant programs. So overall, with that, reimbursement issues, access challenges, and workforce challenges, we're looking at solving three questions, right? How do we solve this innovatively going forward? How do we expand the reimbursement model so that we can be more sustainable in our communities and provide more diverse services that can be reimbursed? We talked about treatment, no transport, and some other treat on scene, telehealth, that sort of thing. We're looking at alternatives to the traditional EMS model. You heard some of that, where in some areas across the country, we're able to transport to urgent care centers, or what we call alternative destinations, so that we can take patients to the right care, to the right care at the right place at the right time. And then constantly working to improve recruitment and retention of EMS personnel within Kentucky itself. So we think while we're stuck with this issue, we've got to innovate ourselves out of it. And that's what we've been working towards with different programs across the state. So appreciate the time to listen to the three big challenges we're experiencing on the ground here. And we're happy to take questions.
Chair recognizes Senator Webb for the first question.
Thank you, Mr. Chairman. I have two. But first, I want to tell them they need to update their hospital map because Greenup County doesn't have one anymore.
Nope.
Bellefonte has shut down, unfortunately. So that makes the desert even more vivid in northeast Kentucky. And thank God we have alternatives across the rivers, West Virginia and Ohio. But we still, have needs. And we appreciate the services that we have. I just thought you might want to tell the committee a little about a non-medical transport. Give us an example of what that is.
When you talk about the mental health patients?
Yes.
So a lot of times those are the voluntary holds. So the patient will voluntarily admit themselves to a mental health facility. And really and honestly, at that point, they just need a ride. So there's really no medical reason for them to be in the back of an ambulance. The problem with that is we get paid if there is a medically necessary issue. If there is no medical necessity, we don't get paid. So that honestly is the tipping point for that scale.
I think that's very relevant to our discussion here, and I think it's a problem, especially now with the gray area between drug addiction and mental illness and the overlap that we see there. But also the authority to detain, of course, I'm just an attorney. I mean, do you want that potential liability or do you want that at all? I think that too is worthy to note and put on the record here.
I mean, I'll speak from a director standpoint and I would say no.
Okay.
For one, you have the burden of increased transports. But then also, as I said, my number one responsibility is that my crews go home in the same shape that they came in, and a lot of times that puts them in jeopardy. So I would go no.
Okay, thank you. Thank you, Mr. Chairman.
Representative Meredith, you're recognized for questioning.
Thank you, Mr. Chairman. And I want to echo what Senator Webb started with there. I think it is very concerning, and I know there's been some discussions about the opportunity or the possibility of moving some of the mental health transports from where we see them now at the sheriff's office to the medical or the EMS services. One, you're shifting from an already short-staffed agency to another short-staffed agency. So you're not really fixing a situation, you're just shifting the burden around. And the other, with regard to the detainee issue, I'm going to give you a real-world example. My dad is still a licensed EMT to this day. He doesn't practice anymore, but he keeps it because he's on a volunteer fire department. But when he was an actual active employee of the EMS service back home, they were doing a medical transport to the VA hospital in Nashville, I think. It's been 15, 20 years ago when this happened. But they had a patient who got up off the gurney and literally jumped out of the back of the ambulance as they were driving down the road. Number one, Dad's not in a position at that point to be able to stop him without injuring or hurting himself. And two, has no ability to detain. And so you have a huge liability concern. You have a huge situation there. It's not the proper situation in trying to deal with this. I know we need to talk about how we alleviate that situation in our small communities where we have law enforcement shortages, but I don't think this is the path that we need to go down.
Do you mind if I speak to
Please respond. Yes.
So we're talking about innovative.
Respond briefly, though.
Yes,
we've
sir.
got another question or two.
So we're talking about innovative solutions. One thing that we modeled in several parts of the country is a secure car model. So basically, it'll be almost like a police vehicle, but it may just be a Ford Focus or something, a smaller vehicle. They walk the patient out. They get in. They're secure. They're transported to the facility. They get out. But those are the reimbursement for those are through contracts, or through funding from the state. So those are just innovative solutions that we've kind of explored and have actually piloted throughout the country.
Thank you, Representative Hart.
Thank you, Mr. Chairman. There's a distinct difference between urban and rural areas, especially in not only other fields, but in EMS and fire field. AMR, you operate agencies in both of them arenas. Could you maybe give us some examples on some programs that you've used, good or bad, whether it worked or didn't work, on how you tackled recruitment and retention in the rural versus the urban area?
So that's the $20 billion question per se, but we've realized that while social media has been a big increase for recruitment in the urban areas like Lexington, Louisville, Northern Kentucky, and even Owensboro, when you talk about the Eastern Kentucky area, connectivity is an issue down there, and maybe not everybody has access to as much connectivity as far as the internet goes. So we've actually found that newspaper is actually a viable form of advertising there. Otherwise, it's just partnering with local officials. We're approaching and working with actively some of the local government, county governments in that area to partner on how we recruit in from the communities, because if you get the community behind the program, the people will come. I mean, because it's about a sense of belonging. We want them to feel like they're part of something bigger, and especially within those counties, getting those county officials on board and getting them to endorse it is a major step in that direction.
Yeah, we've seen success with partnering with county or regional workforce solutions, working with unemployment offices, and like we talked about before, actually we call it an Earn While You Learn program. We put them in there, we pay for it, we pay them a full-time salary while they're in there, and we get them successful and get them onto an ambulance. In some other areas, we're We're backing down on some of the requirements for non-emergency ambulance services. So, for example, in Florida, we just passed a bill that will allow drivers, now these are somewhat similar to EMRs, to work with a paramedic on an ALS call, on an advanced life support call, as long as the paramedic's in charge. But we're looking at that configuration to try to get more entry-level folks into the industry, more exposure, and then once we capture them and they're interested, we can invest in their education, if that answers the question. Okay.
Well, for the last question, we have Senator Douglas.
I will try to be brief. You talked about a number of things, and I know earlier, I think there was a statistic given out, or at least a number given out, about 40% of the calls are non-emergent. As someone who actually worked as an emergency room physician for 4 years, that's pretty darn close. Maybe a little low at times, but the three of us are looking each other's in the eyes and we're saying, yeah, right. One of the things I'd like to know, and I'm not asking for that data here, but I do hope I can get it at some time, and that is the non-emergent transports as they relate to socioeconomic status. The people who call in and who need a ride. Okay, we're talking. The three of us are going to talk real world here. Mm-hmm. Okay, and then some of the data on rural versus urban calls. Again, I just want to throw this out because we need to move on. You mentioned the things in the workforce. You talked about lack of interest and maybe a 20 to 30% turnover from year to year, and then even what we all know is maldistribution. But the other thing we don't talk about a great deal is the motivation. There's not a lot of motivation for people to get off their butt and go work. Again, I'm the bearer of bad news, so put that on my shoulders. And so what we really have to try to do to help not just your area, but all the areas that we have in the Commonwealth is we've got to remove some of the things that inhibit people of getting into the workforce. I know you all are being polite and you don't want to say that. So I'll have to say it for you because I was elected by the people of the Commonwealth. You know, the opioid crisis certainly gives us a lot of challenges. It pulls a lot of our workers out of the workforce. We all know that, all of us sitting here. Public assistance programs, whether we want to talk about it or not, or whether we want to say it out loud, is killing the motivation. Why go to work when you can get it for free? And if there's not enough people in the workforce out there, it is very difficult for you all to maintain a business. You just can't keep paying the continuing elevation of salaries that people are asking you for. And then just this one last thing here. We look at some of our education. There was a recent study that came out, and I wish I had brought that here. But a lot of young people who are graduating from college now are getting out and expecting a starting salary of between $120,000 and $130,000, and unfortunately, it's about 46 or 47. So there's that big disparaging. There's that big difference in what the expectation is and what's actually out there, and therefore we lose workforce because people expect more than what the economy is going to pay them. And I think until we start addressing some of those things, all our businesses are going to continue to have problems in the workforce. Thank you, Mr. Co-Chair.
If I can respond to your first comment,
please.
That's okay. You talked about geographic, demographic differences and how folks utilize EMS. And we've seen that. I don't have the statistics here, but there are differences. And in a lot of places across the rural areas, this is their only access to healthcare. So if you're sick, maybe you don't have a primary care physician, you haven't really taken care of yourself for whatever reason, but then it culminates all the way up until the emergency. And that's when you call 911 because that's the access to healthcare to the system. What we're doing is looking at how to intervene there at that point. So we don't call ourselves a transport agency. We're EMS responders, right? So this is while a lot of things are here in the context of transport, we're looking at ways of how we can intervene into that request for care and provide better means. For example, in 911 centers across the country, we're now implementing nurses that can triage and have the scope of practice to triage these patients and maybe schedule them later. Not send an ambulance. So we're moving in some areas. I know places in Tennessee are doing this now. Is not every 911 call gets an ambulance. Every 911 call will get care or will get coordinated somewhere in a system to make sure they're finding the right care. So those are the changes that are happening in terms of innovations that we're looking at, changing the model.
Gentlemen, well done. Thank you for your presentation. Insightful, very insightful, and appreciate you being here today, and certainly welcome you to stay and listen to the final presentation.
Thank you for having me.
Thank you.
Our final presentation today is going to be most interesting. I had the chance to preview the slides. I'm excited about inviting the International Association of Firefighters representatives to the table for their presentation. And in looking at your slides before you come and present them, as I look through the information, this is going to be a fun history of how we got to where we are. And so, gentlemen, thank you for joining us. Please introduce yourselves for the record. And Representative Meredith, it's called a paddy wagon, is what it's called.
Yeah. Thanks, Mr. Chairman. Joe Barrett, President of Kentucky Professional Firefighters.
Chris Bartley, State Policy and Legislative Representative from the International Association of Firefighters. It represents over 330,000 firefighters, paramedics, EMTs, and dispatchers across North America. Also retired Lexington firefighter paramedic. Went to class with Representative Hart. Don't hold that against me. Retired from Lexington last year. I got the beard and now moved over to Virginia. So good to be back. So it's been a few years since I've been up here. Thank you, co-chair and committee of the EMS task force. The EMS field, like the rest of healthcare, is facing critical shortage. There's going to be a lot of copies from other presentations. But the recruiting and retention of EMS personnel was already in effect before the pandemic, and it just exacerbated it and probably left it up over 10 years, and it's made it a lot worse. There are some outstanding and intelligent people in the EMS world. They work in a blue-collar job they are highly skilled, but usually with low-paying benefits. You throw in the pandemic, and now the workforce has been beaten down. They work constantly, no work-life balance, and they are mentally and physically exhausted. So what I was supposed to look at was trends nationally of what is happening, especially after the pandemic, and basically who is picking up the steam of the EMS world. And even though the firefighters are also having shortages, communities within the fire department within the communities are left to basically take care of the patients. Going to go over the history of the EMS and the EMS and the fire service trends, and just describe what fire-based EMS. It's good to know history. I know a lot of people don't understand. I get calls all the time. Why do we send fire trucks to EMS calls? We're paramedics too, EMTs, and it's for manpower or staffing, I should say. 60 years ago, there was no real EMS in the United States. You were probably picked up by a funeral home, and they did call it paddy wagons, I guess. Attendants had very no experience. You'd see the people in the white coats, they just throw you in the back of a truck and just leave you, and somebody drive you to the hospital. So you probably didn't have somebody back there. Basically, over time, through the World Wars, Korea and Vietnam, basically figured out you had better survivability rates by being shot or called shrapnel overseas rather than a car wreck on I-75. So obviously a national issue. In the 60s, they started discussing this. The white paper, the Accidental Death and Disability, came out. That was created to put EMS under the Committee of the Highway Traffic Safety, drafted BLS, ALS standards. We'll talk a little bit about Dr. Nagel, the father of paramedicine, worked for who's a doctor down there in Miami, worked with the fire department, decided to say, we've got this army here, let's put them into EMS and make them paramedics and EMTs And so that's kind of where that came from. EMS Systems Act was put in 1973. It was put under the National Highway Traffic Safety Administration, which kind of tends to be some of our funding issues. Don't know why it's under transportation, except that's why you're just transporting people. You're not carrying, and it's not an essential service, and it needs to be. Again, worked with the fire department in Miami. They all, kicked and screamed, but they became paramedics. Lexington, it's not well known. You've got Seattle and Miami and several other large cities in the country that started the firefighter medic programs. Lexington started in 1969, and I'm going to brag, it's the leader in the state by hands down. I would think anybody would see that with the paramedics they got in the EMS. Emergency, don't know if you remember that show, but that is that's credited with where fire-based EMS came from and kind of pushed it nationally. I couldn't find the picture of me back when I was like 4 years old. I had like a little doll and I had a stethoscope and had my little fire helmet on, so I couldn't find that picture, but just a little relief. Again, it's quoted before, 1/5 of the healthcare workers have left their job. We're all seeing the workforce shortages, or however you want to call it. Again, paramedics make alternatives to nurses. They're hired in hospitals. I worked in a hospital for a little bit part-time, probably about 12 years ago, and they pay much higher. And they work in more controlled environments. They're not under a flip car and pouring down rain and, doing CPR on somebody or trying to intubate somebody it's a rough job. Trends a day, your private for-profit companies are struggling with recruiting and retainment, just like we are, but they're struggling to remain profitable. Volunteers, for years since I've been here, it's always been trying to retain volunteer firefighters. I was appointed to the Kentucky Fire Commission under Governor Bevin, and we fought with those issues for that time that I was on there. And it's just not changing. Rural areas continue to provide service. There's been abrupt closures of EMS agencies nationwide. And when these organizations close, the fire service has been there to fill the gap. The fire department is basically left in those cities, small or large, that have been left. And even though they're not fully trained, cities have been called us to scramble and try to help them get medics. And the firefighters are the one that's going to have to answer the call at the local level. My point of this whole conversation is fire-based EMS was there in the beginning, it was there before the pandemic, and it's there now. And it's already trending that way. Large cities, Kansas City, Philadelphia, Orlando made the move. You've got small towns in North Carolina, Massachusetts, small rural communities, their fire departments. Your volunteers are kind of going away, and some locals are having to decide they have to pay their departments. They have to become part-time or fully paid. And those are the people that are answering the calls. Also seeing mergers of counties and districts. Just worked with Washington State. They had a couple of mergers to kind of maximize their services. Working on several, it just depends on whatever your taxing districts can do. And I know that they're pretty limited here. So that's one of the things you might have to look at is consolidation of some services at the county level and or city levels. What we're also seeing is once the fire departments are getting, becoming the EMS transport for their communities, they're bridging the gap by hiring from the private for-profits, and they're bringing them as single role medics. They can't go into fires, but they can still serve as paramedics. So we're seeing that happen as well until basically to bridge that until they can get their training as firefighters. Currently, just during the pandemic, we've seen Atlanta go away from their private service. They've started doing their own ambulance transports. Small towns in Ohio, voted the city council to end their contract with Smith Ambulance. The Villages, Florida, don't know if you've seen those in the news, large community down in Florida that encompasses 3 counties, helped on this project, and the fact that the citizens got tired of slow response times and ended their contract with AMR, and they voted to have the county fire department and the city of the Villages do the fire transports, the transports of the fire department. So they bought 12 ambulances. They already had the medics on there at least. They didn't have the hiring problem. But they bought 12 ambulances. I actually saw them at FDIC in Indianapolis in the spring. So it was good to work on that project. Blackjack, Missouri, small suburb out of St. Louis. Again, citizens were tired of waiting on 911 calls. They did a fund, levy basically, a vote of the citizens, and they voted to hire medics and hire 15 medics and 4 ambulances, 3 or 4 ambulances, to make runs for that district. That was and do it and kind of make the backup be the Christian EMS hospital system. I've also seen in this state with Jefferson County fire districts. They have moved to, even before the pandemic, they moved to merge, create taxing district, or they were already taxing districts, but created transport units because of the service provided by the city. And it was just kind of, they were just stretched to the limits. As previous stated on the first presenter, the fire service is the predominant provider of EMS transport in the United States, not here in Kentucky. 97% of the 200 most populated communities use the fire-based EMS system. And basically nearly all firefighters have some level of EMS training. We have a built-in infrastructure. All our stations are built in a certain community. We have a ready army to go to war basically and make runs and make EMS responses. And we can make all hazard responses. So if somebody has an incident that's a car wreck, you can actually start treating the patient and you're ready to go, and you have either a high angle rescue, hazmat situation, and we had to learn how to start IVs in hazmat suits in our training. And so we can do an all hazards response. Here's a basic thing, but it's kind of silly, but again, most of our engines around that do fire-based EMS have everything on it except for a stretcher that an ambulance does below. Fire departments are government entities, have no profit motive. Therefore, they're the priority of the patient and the taxpayer and the person that calls 911. It is, again, more robust system. It provides a seamless transition to care through all stages of emergency response, from fires, emergencies, hazmat, technical rescues. And even we already do the community risk reduction programs, fire safety programs. We do EMS reduction programs as well. It's not a distraction from our mission. It's a core service provided by firefighters and paramedics within the department. Response time is also an absolute priority for medical emergencies, and that's all medical emergencies. They're best positioned to respond quickly and provide vital services on scene. We are strategically positioned to deliver critical response and effective patient care. And we also have standards through the National Fire Protection Association for 4 and 8 minute response times. Even though we do have staffing shortages, we do have very low turnover rates compared to the rest of the EMS world. They are long-term workers in their communities, and they meet their community needs through those responses. Again, more advantages, continuity of care. If they belong to the same agency, almost as well as even within the same government body, you've got the same training, continuity of administration, pay, benefits, hiring, training, promotional processes, all within a city or county. And they control basically who they hire, fire, discipline, or pay more. Again, continuity of medical direction, unity of command, and using the same medical equipment. Going through the reimbursement resources, it's going to be the dead horse here, pretty much. Medicare, Medicaid only reimburse, transports to ER, basically some of the same stuff. Medicaid reimburses at approximately 10% of the actual cost, so we know we got issues there. One thing that we're looking for is the treatment in place. It was mentioned before in the last couple of presenters. If somebody has a low blood sugar, you're treating them on scene, there needs to be a reimbursement model for that care, you know, and that would help some of those funding mechanisms. It saves time and money by avoiding unnecessary ER visits, but at this time there's very limited Medicaid and or private insurance reimbursements. Telehealth, something that I think is coming of age. Again, allows us to communicate with physicians and maybe get the stuff that they need and the care that they need without actually taking them to the hospital. Alternative destinations, already explored a little bit. There needs to be access to urgent care, mental health providers within care of that, but reimbursement needs to be considered. There are other cities around the country that are considering Uber and Lyft, and obviously that would be in more urban areas. Other innovations, we're looking at federal legislation to basically reimbursements happen they're reauthorized every 6 months or 24 months. We're looking at extending that time over several years so EMS agencies can predict more assist in planning in EMS budgets, basically. So it provides that over time. Properly count EMS providers. The Bureau of Labor and Statistics actually does not recognize dual role EMS fire personnel, and actually requires respondents to either put firefighter or EMS personnel. So the EMS personnel around the country is drastically is misinformed, and actually there are more, but it's the way the agency just classifies them, and it needs a change. In turn, that leads to less funding for EMS nationally. Let me go back here. Community paramedicine program, I want to hit on that. I'm going to brag on Lexington again. I don't know if you see the news. It helps with opioid overdoses, your chronic illnesses, diabetes, high blood pressure, and keeps people out of the hospital and saves hospitals a lot of money and taxpayer time as well. But that program that was okayed through K-Beams a few years ago has worked wonders in Lexington. And I believe it's in several other communities as well. Stakeholder engagement is vital. I hope that this task force looks forward and works with all the organizations, all the fire organizations, fire chiefs, firefighters, privates, hospitals, and basically looks at what's best for the citizens of Kentucky and their 911 response times. And basically, you know, I'm going to advocate keeping everything local control at the county or city level, because they're the ones that has to answer the calls of complaints and when things don't go right. There's a physical, mental toll that's being on EMS workers, firefighters, first responders, and there's going to be a need to help these firefighters, especially after the pandemic, first responders, any of them. So especially after what you've dealt with, I came in and helped with the tornado in Mayfield and got the flood going on. It's been a tough year for Kentucky, tough couple of years. Funding needs to be available for all these telemedicine, alternate destinations, training, recruitment. And one of the things that we looked at, Michigan just passed a budget that allocated $12.9 million to boost Medicaid reimbursements for EMS. When combined with federal match, that is nearly a $50 million that will benefit EMS in Michigan. That's all agencies in Michigan. There was an additional $5 million grant to help local governments recruit and train first responders as well. And the last thing, again, pay benefits, defined benefit retirements, and work-life balance have to be seriously considered for all the personnel. It's a much-needed need. Any questions?
Gentlemen, thank you for the presentation. I'm confident some of my colleagues on the panel may have some questions. One of the points that I think we've heard over and over throughout the day is on the question of reimbursement. And a lot of conversations about workforce, retention, attraction. I'm not going to say that increasing reimbursement would fix that, but it would certainly help that, I would think. If we reimbursed more for the services, you could potentially pay more and attract and retain more talent. So with that thought in mind, I've asked staff to work with our folks at the cabinet to provide some recommendations around this question specific to reimbursement. And back up to your slide number 15, Medicaid reimburses approximately 10% of the actual cost. Are those Kentucky numbers? Or are those national
Those are
numbers?
national numbers. I've got that from our he's our legislative liaison, EMS expert at
The
the
national
office.
numbers, 10% of the actual cost. So not to diminish your presentation in any way whatsoever, movement toward a privatization, moving away from privatization toward taxpayer-funded operations is obviously a cost shifting. It's got to be paid somewhere. If Medicaid's not going to pay it, am I wrong in my thinking that moving it to a taxpayer, you mentioned some entity had imposed a tax on themselves to provide for fire service taking over the emergency medical response. So we can pay for it either way. It's got to be paid for, in my mind. Thoughts?
Correct. We are not for profit. The fire service is,
Right.
I mean, it's there to serve the community no matter what. And they're being paid to be there, at least the fully paid firefighters are there to be there 24 hours a day.
Sure.
So you've already got this army that is in place. This staff is there. And if they're trained properly, they're already being paid to do that. And they might as well make EMS runs as well and make transports. So it's already within our DNA to make these runs. And you're looking at what is the needs of the citizens as well. If we looked at, in Lexington, there was a battle to reduce EMS cost and response times and take people off the ambulances. And you start talking about that, the mayor did at the time, and then once the council got a hold of it, it's like, not in my district. My citizens expect proper response times, proper care, and that's what we provided. We actually had EMS, ER nurses and doctors come and testify for us. It's basically whatever the community needs. But we're already not for profit. I mean, and so we're looking at reimbursement rates. We're not trying to get rich,
Sure.
but we're trying to subsidize that cost of providing that care.
So the revenue stream to provide that service in Fayette County is via a tax on the citizens?
No,
How is it
they
funded?
they just get the reimbursements through Medicare, Medicaid, and then I believe the community paramedicine, I believe the hospital systems fund some of that to subsidize that as well.
Okay. Representative Meredith.
And Chairman, I think if you look across the state in many of our rural areas, we have a very similar type of situation to what we're talking about shifting that cost. Medicaid is only paying a very small portion of what the Medicaid cost is. And if you look in our taxing districts that are either fire and EMS combined taxing districts in places like Jefferson County, or in your smaller communities like Edmonson County that we represent, where you have an ambulance taxing district, it's really the property taxpayers who are paying that tax rate that are subsidizing the EMS service that is not being covered by Medicaid rates or Medicare rates and private insurance. And I think that would be something that you would see in many of the rural communities across the Commonwealth, because I think that you have the for-profits that are operating in some areas, you have hospital-based in some rural areas, but for the most part, I would think that the state is covered by those taxing districts like that are subsidizing through a property tax, through some type of a fee type structure, or the local government, the county is paying it somehow out of the general fund. So I think you see that broadly across the state, not just in the urban areas with a fire-based service like you all had in Lexington, but in a lot of the rural areas with the taxing districts or government-run agencies as well. I think if we looked at this, that issue of treatment in place or community paramedicine or however you want to look at it has a whole lot of promise of trying to right that ship as well, because again, if you're not transporting, you're not paying anything. That doesn't mean that they're not shelling out a cost to be able to take care of that patient when they're asked to respond to like you said, whether it be someone with a sugar issue or whatever it may be.
Mm-hmm.
Many of our rural and underserved areas, they don't have that local doctor in their community or the access to that local doctor because they're overworked. And so it's an option that I think could take care of a lot of the woes that we see in EMS, but also make our population healthier as well.
Senator Webb, you have a question?
Yeah, briefly. And if you go to a fire-based model, what's the optimum complement, like per shift, for your demographic? Is it population, miles covered? I mean, is there a model that you're familiar with, or do you just have to come up with one yourself based on respective community?
So we provide standards through the National Fire Protection Agency, and so you look at staffing of engines or ladders, and you have to have so many engines or ladders and ambulances, and if you try to meet the 4 and 8 minute response times, talking mainly urban areas, obviously.
In a rural area, where
rural area, I mean, you try your best. But you look at your models where you want to build your fire stations, build your personnel.
You've got problems. If you want to go to a fire base, a lot of cities can't sustain, the retirement benefits for a full complement, but yet they can't afford the ambulance contract either. So you've got to come up, do your due diligence, I guess. But I was just wondering if there was a model to help cities, look at that, maybe to budget.
If I may, coming from your senatorial district in East Kentucky, basically in the rural areas like that around Ashland, where I'm from, they do the best they can with what they have, and just like you mentioned the lack of hospitals in Greenup County and in Carter County, that they're constantly transporting patients from Carter County into Ashland to King's Daughters, which, as he stated earlier as well, it leaves a shortage of EMS protection in Carter County while they're spending so much time in Ashland. So I'm sure that the Carter County Ambulance Service is taxed to the limit as well. They would have to be, as much as I see them in my city. And so like I said, I think in those kind of communities, they do the best they can with what they have. And that's why we've advocated not only funding for the metropolitan areas and the urban areas, but there needs to be funding provided for the rural areas as well. Oh, absolutely. Mm-hmm.
So I'm also helping Arizona a little bit. There's a proposal that goes to all the voters of Arizona, and again, this is obviously Kentucky, I guess, doesn't do this, but would allow taxing districts a certain amount that would sunset over 20 years, and it's basically for those rural areas of Arizona that aren't covered by Phoenix or Tucson that aren't really cash strapped. So it's there's changes that got to be looked at that maybe you can look at alternatives. At least the voters would make that choice, and it would statewide as well. And even though it only helps probably 40% of the population, it's there for everybody to vote on and look at. So I'm helping with their tax initiative there.
It's good. Co-Chair Fleming.
Thank you, Co-Chair. Wanted to ask Holly one quick question and then more of an explanation of how y'all handle something. I got a pretty good background from Chief Briscoe this past spring on how y'all operate and so forth. It was very, very helpful. Want to ask, in terms of breaking out between emergency and non-emergency, can you break that out, particularly for Kentucky, in terms of your runs?
I would say the 40% probably is right on, as Senator Douglas said.
Okay.
I would say that's probably. It's hard to say what is emergent or not. I look at what the patient is, and when I've made so many calls in which we walk up and it's like it's not an emergency and it turns into one, and it could be grandmother's got her stomach hurts and it ends up being appendicitis when it's like I just got bad gas, and it turns out to be something more. And I get that overall it probably isn't, but we always do walk in and it's like, this is not an emergent call and we're here and let's take them to the hospital and let's get the care they need and the attention they need almost.
Okay. All right. I guess it goes back to having good data collection, and that's one thing we need to work on.
It is it's
Yeah.
an awful issue. Even in the fire service, it is as well.
Right.
But also emergency dispatching might help with that, to where they might be able to signal some of those calls and maybe weed some of those out.
On my second question, could you explain how do you handle mental health patients, clients?
Lexington.
Yeah, because of the one of the presenters mentioned that liability issue.
Yes.
And then they went on and explained some other things. So how do y'all go down that process?
So there's got to be a lot of things in place, but from my understanding, when I left Lexington a year ago, basically the police transported patients to, say, Eastern State, or if we went to Good Samaritan or whatever, UK Healthcare. I'm old school. A police officer would have to ride in the back with us, because I've had the same scenario that the previous presenter did. Somebody just jumped out in the middle of Alumni Drive on me, and I was like, I'm not stopping you, but I'm calling the cops to stop you. So, but from what I've been told, because of the shortage in the police department, we're transporting to Eastern State and those facilities to facilitate that.
Okay, thank you.
Representative Hart, last question, sir.
Well, it's more of a comment than a
Maybe not
question.
last
Going off of Representative Fleming's last comment, what might be beneficial is Lexington Fire Department. They're working with Eastern State, and they've got a new program to help facilitate better mental health transports. So it might be beneficial to this committee to maybe see if Lexington would come and give us a presentation on what they're doing.
Staff will note that as we're designing the agenda for future meetings. And Representative Meredith for the last question.
Thank you, Chair Givens. And just to further state what I was talking about earlier about that subsidization, something that we all need to be aware of as we move into the future. EMS or fire or combined fire and EMS have a statutory cap on the tax rate that they can charge as part of that subsidization process. 10 cents per 100 is the statutory cap regarding an ambulance service or a fire service separate from each other. If they have a merged service, they can have up to a 20 cent per 100 cap on that property tax rate. But especially with the increase in cost regarding retirement benefits, and as we continue to see a pressure on wages, and that being one of the big drivers of cost, many of our rural services are getting near or dangerously near that tax rate cap, and they have no relief once they get there on that subsidization piece.
Well said, well noted. Another productive meeting. Thanks everyone for being here. I would ask Director Sloan, before you leave, I'd like a word with you, if I could, please, sir. And everyone take note, our next meeting is September the 20th, 3 p.m. Eastern. Thank you. Meeting's adjourned.